Good afternoon, everybody. I hope you are all having a great week so far. So, before we get started on our quiz, I wanted to go over the whole two device. Oh, Ashley, you have a friend. So cute. Um, I wanted to go over with you guys the whole two devices thing because I gave you the wrong information. So, for both our quizzes and our exams, you guys will need to have two separate devices for testing. You'll have your Zoom on one of your devices. Typically, I feel like students use their phones for the Zoom. And then your computer, laptop, tablet, whatever it may be that you want to use to actually test. Okay. You don't have to be on Zoom on two screens. Like we don't need you to be on Zoom on both your computer and your phone or what other device. You just need to be on your screen and testing on a separate device. Does that make sense?
Yes.
Okay. So that's how we're going to do it for the quizzes and for the exam. So I apologize for giving you guys the wrong information at the beginning. Um, about quiz one. So I don't know if you guys checked your score, um, but we ended up giving the point back for that select all that apply question for quiz one. So it turns out that that question was actually pulled from a study guide from a different resource. And one of the students sent it to Professor McBride and was like, hey, there's actually only one answer in this question. I was using it to study. So we're like, you know what? We're just going to give it back to everybody. So if you see your grade has changed, that's why we just gave everyone points back for the select all that apply question. Okay. So if Janaea, if you'll come on your screen for me. And then I know Linda was in the Zoom, so we'll give her a second to get on the screen too. And then we'll get quiz two started. There you are. And then Christian, if you can also put your camera on. Wonderful. Thank you so much. Okay, if any of the people that were in the Zoom when we started class come back in, if they got kicked out or something, I'll just give them the code independently. But since you guys are all ready, the same thing applies, okay? Um, you have 15 minutes, it's 10 questions. Do your best. Um, and here, if you're ready for the code, I'm going to give it to you now. So the code for quiz two is fetus with a capital F.
And we go. I'm sorry, my literally just went blank on me. It's trying to charge.
Oh, it's okay. If you have to restart or something, I'll give you the code again and you can take it. All right, if everyone wants to come back on screen, we'll get class started. Okay, so first I wanted to offer you guys, I've been offering my later class the opportunity or the option of if you guys would like to get out of class like 10 minutes early rather than taking our break. If that is something you guys would like to do, just go ahead and raise your hand. If not, we'll just plan on going with the normal break and all of that.
What was the question?
If you guys would like to get out early rather than taking our 15-minute break. Okay, I think we'll plan on just getting out a little bit early. If I have to get up to use the bathroom, I apologize. Since I'm pregnant, I do that like every half an hour. So I might have a like 5-minute bathroom break. But other than that, we'll try and end then around um, like 4:30 my time. Okay. Um, so there's a couple of things I want to go over with you guys in Canvas before we get started on our classroom PowerPoint. So let me share my screen here. I'm going to pull up some announcements and our assignments for this week. Okay. So the biggest thing about this week that I want you guys to be aware of is we're starting to host our exam review sessions to prepare us for exam one, which is going to be next week. Okay. So this announcement should have come to your guys' shell, the exam one study session, schedule, study material, and recordings. So if you go in here, you're going to be able to see um, all of the scheduled dates and times with each professor and where what their Zoom passcode is. Um, and this information up here too is really helpful. So if I were you, I would look at this exam one blueprint. I think that helps really narrow down what you guys should be studying. It's a really good resource for you to reference because there is a lot of information, right? There's a lot of material. So trying to narrow down exactly what we should be focusing on is part of the hardest part about school, I feel like. So this exam one blueprint is going to go through with you the things that I think you'll find to be the more important on the exam. Okay. Like I said, down here is all of our times and dates with the review session. Mine is going to be on Friday at 4:30 p.m. Eastern, so this Friday. Whenever a review session has happened, I'm going to get the recording from that professor from their review session, and I will update it in this announcement for you so that all of you guys will have access to those recordings if you're not able to make the review session for whatever reason. Okay. So just keep an eye on this announcement. Every time I update it, I'll send a notification that you guys should get in your Fortis email, just saying that I put in the recording from a professor's session. Okay. That is the biggest thing with the exam review. I think they're super helpful if you guys can make it to at least one of them. I think that'll be worth your time. Um, all of us do things a little differently. Like, so for example, at my review session, um, for my review session, I'm planning on just doing like some Kahoot review games. Um, but all the other professors do things just a little bit different. Okay. So let's go back into our announcements here. With the exam next week. Okay, we're gonna go over some stuff with that really quick. You also got this announcement in your shell, the Exam Soft Practice Exam. Okay. This is going to through with you. It gives you the password for the access code for the practice exam. You have to take the time to do the practice exam before next weekend on the device that you're going to be using for testing. That's super important, okay? So do not try and download the practice exam on your phone, and then when test day comes around, try and take it on your computer because it's not going to work on that because you won't have that program on your testing device. So whatever device you're going to plan to use to test, you should use whenever you're doing your practice exam. Okay? This helps to ensure you have completed the software update, and then it'll help you understand how to navigate it as well. Okay, and then if you need assistance registering for ExamSoft, there's a link in the student resources in the modules titled How to Register for ExamSoft. Okay, so try and do that sooner than later because I've already had some students reaching out to me that had some issue. ExamSoft, whenever we start a term, they have to put all of you guys into my course, and then you would get a notification whenever I've released or there's a draft available for you to download. At the beginning of this semester, for some reason, none of my 5:30 p.m. class got put into ExamSoft, so they weren't able to even see that there was a practice exam available. You guys should all be able to find it and download it. You'll have to re-upload it into ExamSoft to get credit for the practice exam. That way you can take the exam next week. Okay. So try and do it. Follow those instructions in the how to register for ExamSoft under your student resources module and reference this announcement too. Any questions about that so far? Awesome. Okay. A few things for our exam as well. So next Tuesday, you guys are going to be getting in how to test or testing day is tomorrow, big announcement in your shell. And it's going to break down everything that you need to know for the test. Okay, we're going to go over it a little bit right now. But then it's going to be a good refresher for the night before because it's always a little bit slow start whenever we're taking the first exam. So, like the quiz today, you're going to need to have two devices. Okay, you'll have your phone with your Zoom that has you in view of the Zoom, and then you'll have your device that you're testing on, laptop, computer, whatever you need or whatever you're using. You're allowed to use a calculator. You're also allowed to use a whiteboard, dry erase board. I just need to see it at the beginning and at the end of your exam to make sure that there's nothing written on it and at the end of the exam, you've erased everything that you had written during the test. Okay. At the beginning of the test, I'm going to have to ask everybody for their student ID. You'll show me your student ID. You'll also show me a 360 view of your room that you're testing in, as well as the testing surface and underneath your laptop or your testing device, just so we can make sure that nobody's trying to cheat and that everybody's prepared for the exam. Okay. You have 75 minutes to complete the exam. Once the exam is complete and you've shown me you've have that uploaded green screen with the check mark on it, you're welcome to shut your screen off. Stay in the recording just because that will count towards your attendance if you leave the Zoom completely. And then once everybody is done, usually after exams, I just go ahead and do the 15-minute break at the end to let people who like took longer on the test get up and use the bathroom, get a drink of water, whatever. Then we'll come back and we'll still have class after the exam next week. Okay. We'll go over all of this again next week. And like I said, keep an eye on your shell because I'll be sending out an announcement around like Tuesday night that has instructions for exam testing day. Okay. Awesome. So let's go into our modules really quick. We'll go over what's due this week and then we'll get started on our PowerPoint. Okay, so this week you guys have your sim chart, your infection sim chart that's due. That'll be due by Sunday night. You're also going to have your first assignment for those NCLEX questions. I can't click into any of these things when I'm in student view, so I'm just going to go here. You have this, your first assignment of your NCLEX questions that will be due. If you click into the actual assignment, it gives you all of the instructions step by step of how to complete this correctly so that you get full credit. Okay. So please follow this. If you submit it the first time and you submit it on time and there was something that you did that I need you to change, I will send you a message in Canvas and then you can just resubmit it. And if you submit it on time, I'm not going to take away, like, take a late penalty or anything like that. Okay. But just try and read these pretty thoroughly so that you know what you're doing when you submit them. Okay. Sim chart is the same as last week. Okay. You'll just need to complete that by Sunday night. All right. Any questions? Sounds good. Okay. Let's go ahead and pull up our PowerPoint for this week. Let's get started on the content and we'll go from there. Everything's moving kind of slow for me today, so bear with me here. All right, let's review from last week. How does the placenta provide oxygen and nutrients and remove waste for the growing fetus? What do you guys think?
The umbilical cord?
Yeah. So the overall anatomy, right? So you're right. The right here, the umbilical cord is attached between the placenta and fetus, and it brings in oxygenated blood through the umbilical vein, and then it removes waste through the umbilical arteries. It also is responsible for it diffuses between maternal vessels and fetal vessels in the placenta, and it relies on maternal blood pressure for perfusion. So in my recording, whenever I talked about like fetal circulation, blood flow, excuse me, between mom and baby, this is important for this question, right? Because we want to know how that anatomy works. How is it that mom's blood pressure, why is mom's blood pressure um, important for perfusion to this placenta? So, for example, let's say mom has really high blood pressure. Is that placenta going to get the blood that it needs? Is it going to be perfused well? No. So if mom has blood pressure issues, we're looking at a disruption in the entire circulatory system between mom, placenta, umbilical cord, baby, and back out. So we need to know this really well. We need to know the blood flow from mom to baby and how all that works, and what the placenta's role is in that process. Okay. What are three danger signs that the nurse should educate the pregnant client to report? So what are some things we want our patients to call their doctor about?
Things
Excessive
like,
bleeding.
yeah,
Excessive bleeding.
bleeding,
I was about to say.
Yeah, you guys got it.
bleeding,
Yeah, bleeding.
cramps, I guess that
starting to feel like, I guess you can call them contractions, but they may just be cramping, feeling real bad in your stomach. That could be a problem.
Yep, definitely.
You haven't felt the baby move in a while?
Fetal movement. What are our rules for kick counts? What do we talk about or tell moms to do?
Ooh.
10 kicks, kick, 10 kicks per hour.
Yep, 10 kicks in a 1 to 2 hour time frame. Yep, you got it. So you guys got most of these. Yep. So absences or changes in fetal movement. Fetal movement, especially in the third trimester, is one of the biggest indicators for fetal well-being. Okay. If moms are feeling a change in fetal movement, it doesn't necessarily mean like they're not feeling any, right? Because I could have a super active baby that is constantly moving and moving and moving and moving. And then I'm 37 weeks and a couple of days pregnant. And all of a sudden, my baby's just not moving as much as they usually do. The sleep wake cycle is a little bit different than what it typically is. Even things that are like a little abnormal than what they're used to, we want them to tell their doctors about that too. Okay. But yeah, our rules for kick counts are 10 movements within 1 to 2 hours. They should be done at the same time every day. Typically, mom should be laying on her side for the kick counts. And if she doesn't feel movement or she is doing these kick counts and she doesn't feel movement, what are some things we can suggest to her to try?
Taking a hot shower.
Yep, we could have her take a hot shower. What about drinking lots and lots of water? One of the biggest reasons that moms will have cramps, especially in the late second and third trimesters, is because they're dehydrated, right? We have to think of our uterus as a giant muscle. That's basically what it is. So, whenever you're dehydrated, your muscles are going to experience cramping, right? If you're malnourished, if you haven't been eating very well all day, if a mom calls into the unit and she's like, "Oh, I'm a nurse. I work at the bedside and I've had 8 patients all day, all by myself. We don't have any techs on the floor. I've been running around like crazy. I haven't had any time to eat, and now I'm having some spotting. I haven't really felt my baby move, and I'm having some cramps." Probably the first thing I would tell that mom is you need to sit down and drink like 3 jugs of water. Um, and then also come in to be evaluated. Okay. At that point, if it's been all day that she hasn't been feeling movement, yeah, we need her to come in immediately. We're not going to tell her to mess around with doing things at home. But you can tell moms to drink lots of water, but ultimately we will want them to come in and be evaluated. All right. The second one, blurry vision, a headache unrelieved by Tylenol, right upper quadrant or epigastric pain, and heartburn accompanied by a headache. What are those things indicators for?
Is it gestation or
So it would have something to do with like something abnormal that moms can develop.
Preeclampsia or high blood pressure.
Yes. Yep. Preeclampsia or high blood pressure. Um, so we definitely want them to notify us of that. Okay. So like I said, with our blurry vision or headache, those can all be things that are caused by elevated blood pressure. If they're trying to take Tylenol and it still doesn't go away, that would be a warning sign. That right upper quadrant or epigastric pain, I want you guys to, Gladys, I think you're writing your notes right on our PowerPoint.
my bad?
It's all good. Um, So we want them to definitely report that. I want you guys also to remember specifically that right upper quadrant epigastric pain. It should be associated with you. If you read those on a test, you should be thinking that could be a preeclampsia. Okay. Bleeding. Anytime a mom has any bleeding, we want to know about it. In the first trimester, we're going to be doing some things to rule out like a spontaneous abortion or a miscarriage, or even ectopic pregnancy. In the first trimester, that's what that bleeding can indicate. In the second and third trimester, bleeding can indicate a lot of different things. So, One of the ones that we're the most concerned about would be a placenta previa. That's what happens when the placenta grows over the cervical opening. So that placenta is developing first. So we'd be worried about that. Any leaking of fluid or contractions or pelvic pressure prior to 37 weeks, what are we worried about? See how it says prior to 37 weeks? What would that?
Preterm labor.
Yep. Preterm labor. So these are things that we're educating moms on probably at their 24 to 28 week appointment. We're telling them if you start to experience any of this pelvic pressure, any regular contractions that are timeable, we need you to come in so that we can ensure that you're not going into preterm labor. Flank pain and painful urination sometimes can indicate preterm labor as well, but also we want to be on the lookout for a urinary tract infection. So those are some things that we want moms to call in about. Next one. When do we start measuring fundal height? How do we measure fundal height? And what measurement is normal? What is anticipated?
14 weeks. Is it 14?
Is it starting at 12 weeks?
I believe it starts a little bit later than that.
20 weeks?
Yes. So it starts around 20 weeks because that's when your fundus is at the umbilicus. So that's when the mom's fundus should be right at that belly button point. And you're going to measure from the pubic bone to the fundus. And your centimeters should equal the gestational weeks, plus or minus 2 centimeters. Okay. So I remember last week we had that practice question that was like a mom came in for her standard prenatal appointment. Her fundal height should be measuring at what? And she was 36 weeks pregnant. Her fundal height should be at least 36 centimeters, give or take a centimeter or two. Okay. So I would just know that for sure. You might have a question about that on your exam. How to measure fundal height and what the normal fundal height measurement should be. Okay. What are 3 signs of pregnancy and what are 3 examples of each?
Ask that one more time.
What are the 3 signs of pregnancy and what are 3 examples of each?
Is
Uh,
the positive one is the blood test?
So if you're a positive sign of pregnancy, what do we have to see or hear?
a heartbeat
Loss of menstruation?
or see a baby
We have to see the
or a
baby.
fetus.
Yep, we got to see or hear the actual baby that's in utero for it to be positive. So what would be an example of that? A positive sign?
Ultrasound, X-ray. What was the other one?
Listening.
Besides hearing, yeah, I'm like, that's it. Besides hearing, just those 3.
Yeah, a Doppler. Yep, hearing the baby with a Doppler. So think about if you have a positive sign of pregnancy, it always has to come from the baby. So you have to either see or hear that baby themselves to know that that mom is definitely positive pregnancy. What are the other 2?
You mean like the missed period or the pregnancy test?
Yeah, so what would be the other 2 categories? So we have positive. What were the other 2?
Probable.
Probable.
Mhm.
And
And then
presumptive.
Yep, presumptive. Yep, probable and presumptive. So what would be like a presumptive sign of pregnancy?
You miss your period's late.
Yep, yep. Missing a period.
What else did the thing say?
So I think last week, CJ, you mentioned it was like subjective to the patient as far as presumptive. So what are some things that a woman could say she's experiencing that may lead her to
Okay.
believe she's pregnant?
She can say like her breasts are tender. She's, her appetite's
Nauseous.
changed. She's throwing up. Yeah, there we go.
Yep, yep.
There you go, Gladys. Wingman of the year.
And then what about probable signs? So things that like we usually are like, yeah, you probably are pregnant, but we can't for sure say yes because we haven't seen or heard your baby.
So the pregnancy test.
Yep, a pregnancy test, HCG, elevation. All right, so here we are, presumptive. That S for subjective. So amenorrhea, no period, missed period, breast changes. So mom is saying, "Oh, my breasts are just really tender. They're sore. Um, I've been uncomfortable. Nausea and vomiting is a big one. Fatigue, frequent urination, quickening, and then pigment changes of her skin." What I want you guys also to think about is all of these things can be as a result of a lot of other stuff, right? So you are only going to see and hear a baby in utero if a mom is pregnant, right? That would be kind of crazy. You're not necessarily always going to have breast changes with pregnancy or nausea and vomiting. So this is some stuff that can also be pertinent to other things that could be happening to mom, or she's having an elevated amount of stress. You know, that can cause women to miss their periods. Things aside from pregnancy can cause these changes. Okay. Probable, those are the ones, like we said, right in the middle, where, yeah, typically this means that you are pregnant and we go by them. But they can't be confirmed as pregnant until we get the ultrasound. So your pregnancy test, your HCG levels, your Chadwick sign, your Braxton Hicks contractions, Hagar's sign, Goodall's, and McDonald's sign. For your exam, you guys definitely should know what all those signs are. So make flashcards or whatever you need to do to remember what each of those are. Okay. So like I said, those things typically we see with only pregnancy, but we can't use those as a diagnostic indicator. Okay. We need the actual ultrasound. And then positive, that's when we hear from the fetus, the heart tones ultrasound or palpable fetal movement. Okay. All right, last one on our little review here. What are 3 changes that happen in the body during pregnancy?
Hormonal changes.
Mm-hmm. Specifically, which ones?
Your estrogen.
Yep. You got one. Yes, good job. What's the other one?
Um,
Anyone else? Can we help us out here? What's the other hormone that plays a big role in pregnancy besides?
Urination changes?
Yes, mom will have some more frequent urination. What's our other hormone though? Aside from estrogen, what else do we see that elevates during pregnancy?
Progesterone.
Progesterone. Yes. Mm-hmm. Yeah, you guys got it. So a lot of hormone changes. Your mom might be peeing more frequently. What other things can happen in the body during pregnancy?
Loss of period?
Yeah, she's not gonna have a period. Mm-hmm.
I'm dealing like your cardiac or
Yes.
Hyperpigmentation, probably.
Yep. Mm-hmm. Skin changes, definitely.
Sometimes there's some swelling, like their feet will swell.
Yep, for sure. Let's see. So, yep, you guys got them here. These are the skin changes. Let me see. Sometimes, like, we're going to have that lordosis, that curvature of the back. Moms might experience carpal tunnel where their, like, hands are starting to lock up or experiencing, like, almost arthritis-like feeling in their hands. Relaxed pelvic joints. That increased blood volume is huge. Like, we produce about 40 to 50% more during pregnancy. Our blood is, you guys are going to hear about this from the week 4 lecture too, that you'll get access to this weekend. But your mom's body, the reason all these changes are happening is to prepare mom for labor and to prepare her for birth. So your mom is building up all that blood volume to compensate for the amount that the body is prepared to lose after delivery of that baby, right? Because if you think about it, most of the time, moms lose at least 500 mLs of blood with a delivery. And that's if it's standard vaginal delivery, nothing abnormal. That's pretty typical of what we can see. So your body needs to compensate for that. So that is what it's spending these 9 months of pregnancy preparing for. That's why it's building up that blood volume. We can experience that physiologic anemia because while our blood volume is increasing, our plasma levels are not. So it can mirror anemia for our moms. So we need to definitely educate our patients about all of these things, right? All the changes that they could be experiencing. Great job. All right, so moving on now to content for this week. So our stages of labor. What is in our first stage of labor? Break it down for me here. There's two parts, right? You guys.
Would it be I mean the water breaks.
So what is the start of the first stage of labor? You know, like what would be our marker?
Contractions?
Contractions.
So let's see. Our first stage of labor is going to be our onset of labor to complete dilation. So that is when we have our cervix is fully dilated to 10 centimeters and our effacement is 100%. So that cervix is completely thinned out. Okay. It's divided into our latent and our active phase. We also have to consider our transition phase, but we're not really like tested on that too much anymore. It's mostly just breaking it into latent and active. So what would be our latent stage of labor?
Is that like when they actually?
Ooh.
Water breaks.
No, so our latent stage of labor is before we get to 6 centimeters. Sir, can you sit down? Sit. Sorry. So here we are. First stage, this woman has contractions and her cervix is dilating. In our latent stage of labor, that's anything leading up to 6 centimeters of dilation. Our active phase is going to be when mom reaches 6 centimeters until she's fully complete. Okay. What is our second stage of labor?
Is it active?
Is that like the actual pushing?
Yes.
Mm.
So that is the complete dilation and effacement of the cervix until delivery of the baby. So that would include mom's pushing. So second stage, the woman is pushing and she's giving birth to the baby. Okay. So if you think about it, the first stage of labor is the longest, or it should be, right? Unless you have a crazy amount of pushing, but usually providers don't let moms push for any longer than about 3 hours until they're trying to do something different. So your first stage begins when contractions begin. The latent phase is until 6 centimeters dilated, and then the active phase is 6 centimeters until they're complete. Okay. Your second stage is whenever they're complete, which is that full dilation, that full 10 centimeters of dilation, 100% effacement, until that baby is delivered. So this is including our pushing phase. What's our third stage of labor?
I'm sorry, can you repeat the active and the latent phase again? I
Yeah.
was writing.
Yeah, no, you're fine. So your latent phase is going to be whenever your contractions start until your mom is about 6 centimeters dilated. And then your active phase, active labor, would be 6 centimeters until she's fully complete.
No, that's the first stage of labor.
And that is all within the first stage of labor. Yep. So that first stage of labor for first time moms, on average, that's like 36 hours, 24 to 36 hours. For a mom who's had multiple babies, that could be a little bit shorter. It all depends. But typically, what we're experiencing is a longer first stage of labor compared to any of the other stages. So your first stage of labor is basically the entire labor process. And then you get into your second stage, which is when mom starts to push. Okay. So what would our third stage of labor be?
birth that a baby.
Is that like after, like when you start delivering like the placenta?
The placenta.
Delivery of the placenta. Yep. So that is its own stage completely, the delivery of the placenta. And the delivery of the placenta, it really depends on like the delivery itself, but typically a placenta should not take longer than like 20 minutes after delivery to be expelled. They usually come pretty quick after delivery of the baby. Okay. If they're not coming and it's not coming, it's not coming, then we're probably going to have to do something else or some other interventions, or kind of look into like why is this placenta taking forever to show up. And last, our fourth stage of labor, what would that be?
Couple hours after the placenta is delivered.
So third stage was delivery of your placenta.
Okay.
Is it the close up, the healing
Okay.
up portion?
It's your recovery. Yeah. Your first 2 hours after delivery. So that's its own stage on its own is recovery of mom. So that's our postpartum period, our immediate postpartum period. So let's break this down again. We'll walk through it here because I want you guys definitely to know it. So our first stage of labor starts whenever moms have contractions. Okay, that would be our latent stage of the first stage of labor, our latent phase, I mean. So our latent phase is whenever mom starts contracting. She gets to 6 centimeters dilated, she becomes active. That's active labor. That's the active phase, but we're still in the first stage. Okay. She is out of the first stage of labor. Whenever she is fully complete, there's no cervix left and she's ready to start pushing. Second stage of labor is after she's fully complete and she's delivering that baby. Okay, so she delivers the baby in the second stage of labor.
So the second is the actual pushing.
The second stage is anything when she's complete until the baby is born. So it's delivery of that baby. Our third stage is the delivery of the placenta, and that's its own stage all on its own. And then our fourth stage is that first 2 hours after delivery, after the placenta. That means baby and placenta have already been delivered, right? Because those are earlier stages. So your fourth stage is just recovery of mom. Does that make sense to everybody?
And this is the same for like C-sections, right? Or is that like a completely different?
No, no, no. So C-sections, that's kind of hard to put into this, because either it's an unplanned C-section or, it's scheduled, right? So C-section patients sometimes don't labor at all. Okay. Um, so they are not really in the phasing. Other C-sections can start going into labor and be in the stages of labor and then have to go back for like an emergency or something, but that's not typical, so we don't really like include that. We're just talking about vaginal delivery.
But someone, I mean, technically someone can get all the way to 10 centimeters and then have to have an emergency C-section.
Yes, but they would still be laboring for a vaginal delivery. That's terrible when that happens. That's happened before. So yeah, they can make it through the entire first stage of labor and then have to go back for a C-section. But if we're going to go from start to finish vaginal delivery, we're looking at the 4 stages. Any other questions about the stages of labor? You guys definitely will need to know this stuff for your exam, so I want to make sure you guys are understanding it. Okay. All right. Factors affecting labor and birth. What are our 5 Ps?
Passageway,
Passageway, passenger,
Mm-hmm.
hour,
Yep.
hours, position, and psychological.
Awesome. Passenger. passageway, powers, position, psyche. You got them. You guys will need to know this for sure. We're going to go into them in a little bit more detail here on the next slide. But these are your 5 P's of labor. This is how we can determine if labor is going to be effective and what an effective form of labor is going to look like, what this should be, what all this should entail. All right. So here are our factors kind of broken down with things that we need to know about each section. So our passageway, right? That's talking about actual mom's anatomy. What is her pelvis shape? What are the pelvic muscles? How does her cervix? How is her uterus? All that stuff. The actual like components of the passageway that make up where baby is going to be passing through for delivery. Passenger is your actual baby. That's the passenger during labor, right? That's the baby that's moving down through the vaginal canal who we want to expel safely out into the world. So we're talking about our fetus, the placenta, right? Where's that placenta at? Is it healthy? What are we looking at there for the placenta? Our fetal lie, attitude, all of those terms that I went over in the recording. So passenger is your actual baby and those defining characteristics for them. Our powers. Those are going to be split into primary and secondary. So your primary power is your uterine contraction. Okay? Those contractions that are going to be taking place during labor, during the entirety of the labor, that are going to be helping move that baby down through the vaginal canal, those are the uterine contractions. Those are your primary powers. Your secondary power is mom's pushing and mom's pushing efforts. Okay? Oop. Hold on one second. Let me go back. Position, changing positions. Position change during labor is very, very important to get baby into a good position to make their way down the vaginal canal. We'll talk about some specific positions here in a little bit. I'll show you guys some good resources that we can give to our moms, even before they go into labor, so that they have a little bit of education, so they know what they can expect during labor. But changing positions during pregnancy is huge. It's very important. We don't want moms just to lay on their back during labor. We want to give them the opportunity to get up and be as active as possible during birth, okay? And then psychological. This plays a really big role in labor and delivery. We need to monitor our mom's response and emotions to the entire process in general. How is she doing? What is she feeling? Is she wanting non-pharmacological intervention? Is she wanting to use meds? Does she want an epidural? We need to understand these things about mom, where her mindset is, okay? What was her previous experience with birth like? Is this her first baby and she's coming into it without having any idea of what to expect? Because we're going to need to give her some education and help her and coach her through the entire process a little bit better. Is this a mom who's delivered 2 other babies and her last delivery was a traumatic emergency stat C-section and she's trying to have a vaginal delivery after? Because that can all impact whether or not how mom handles labor and how labor goes in general. What is the culture of the person that you're providing care to? How can we incorporate their culture and their beliefs and what they need into their care to be well-rounded nurses? What's their support system like? Do they have a support person who's doing the back massage and getting them water, or do they have a support person who's crashed out on the little armchair in the corner of the room who nobody can hear, hasn't heard it from anything from them? Because if that's the case, we might need to be in the room a little bit more with our patient, right? That might be what they want too. We never know. They might want the nurse's help more than they want their support person's help. So take all these things into consideration when we're taking care of our patient. These are the things that you're assessing as a nurse, all the 5 Ps, and how we think that this labor is going to go and if it's going to be effective. Okay. So breaking this down even more, when we're talking about passenger, which is our baby, right? We need to talk about fetal presentation, lie, attitude, position, and then the baby's ability to adapt to the birth canal. So what are some important structures for the fetal anatomy that help to that baby fit in the vaginal canal? What are some things that babies are equipped with that help the passing through the birth canal easier, make it easier for them? Think about fetal skull.
I mean,
What
they got soft bones.
Yeah, yeah. I mean, they have,
I mean, they don't really, you know what I mean? They can.
I see where you're going with it. I think you're on the right track.
They don't have like their skull fully developed.
Yeah, so what are those separations? What are those called?
Phonicles.
Fontanelles.
Fontanelle.
You were close. You were so close. Yes. Fontanelles. We have our soft spots. We have our fontanelles. Sutures. The suture lines on the baby skull. Those characteristics of the fetal anatomy are what is going to allow for that head to mold, right? Molding is something that you guys are going to hear a lot in this class. Molding happens whenever, like, if mom says, like, or you've seen a mom post their baby and they've got that cone head, the cone head after birth, that's molding. When the baby's head takes a different shape to accommodate the birth canal. So that molding is possible because the babies have those soft spots in their head. They have those suture lines. Okay. That is what allows the skull to shift around during labor to allow them to pass through the birth canal safely. What is the best position for the baby to be in order to deliver vaginally? Think position. What does that
Head
mean?
down.
Upside down?
Your head should be down, right? So phallic. What is the specific word?
Oh, yeah.
Trendle, trendle something?
So we're looking for occiput anterior.
I wouldn't have got that one.
It's okay. You guys should definitely know this. Okay. So go through each, we're going to go through these a little bit more in detail. Okay. So fetal presentation, right? That's talking about like what is the presenting part? What is closest to the opening of the cervix? So that could be your cephalic, your head. That could be sacral. Um, hopefully it's not a shoulder. A mentum would be a chin, right? So that was like what is our presenting part? Okay. How is baby lying in utero in comparison to mom? How is baby lying? Um, and then when we're talking about occiput anterior, that is the position in relation to mom as well as baby's presenting part. So occiput would be that back part of the baby's head. Anterior would mean that baby is in a good position related to mom for a successful vaginal delivery. Okay. Which of these babies over here would be in the best position? If we're thinking occiput anterior,
This is the first one, where the baby's back is toward the abdomen, is the mom.
it would
The
be
second one.
yep, it's that first one, that
Okay.
baby on the left. Okay. So this is an occiput anterior presentation of the baby. Okay. Here's another picture of what an occiput presentation was going to look like at the opening of the birth canal. And then we already talked about this a little bit, but what enables the fetus's skull to adapt to the maternal pelvis during the birthing process?
What'd you call them? Suture lines? Is that what you said? I know we said fontanelles.
Yes, both. So the cerebral sutures and the two fontanelles, your anterior and your posterior. And like we mentioned, during birth, that slight overlapping of our bones can occur, which causes that baby's head to mold, right? Makes baby's head look kind of funny. So here's a good picture of fontanelles and suture lines. So your fontanelles are these little like soft spots on the baby's head. The suture lines are these lines right here on the skull. That's a really good picture of them.
Yeah.
When we get to our newborn assessment, which is like towards the end of the term, we talk a lot about how to assess for any type of cerebral injury that can occur during delivery. And feeling and assessing your sutures and your fontanelles is going to help. Okay. So I would definitely know for the purpose of your exam that the best position for baby to be in to deliver vaginally is occiput anterior. That's our ideal position. Okay. All right. Factors affecting labor, our passageway. What all do we consider when we're thinking about our passageway?
The pelvis, the
How
cervix.
big the baby should.
So that is probably more about our passenger, right? Because that's baby size, but that is important to take into consideration. What are we talking about when we're talking about the passageway? Who is that more prevalent
Is
to?
the mom?
Mm-hmm.
But it's like, is it mean like, is everything opening up enough for the baby to start to be kind of pushed out? Is that what we're talking about in terms of passageway?
Shape
Like
of her pelvis.
pelvis, yeah, like her pelvis shape. So, like, what other parts of the anatomy do we need to take into consideration when we're talking about like labor process? What all is involved?
The cervix, the dilation and effacement.
Your uterus, of course.
Hmm.
I don't know. You got your
But like,
pelvis, your stomach muscles, and you got your breathing, and
yeah. What about your like pelvic muscles?
I mean,
Mhm.
you're gonna be using those, but you're still spreading at the same time, isn't it?
So we're looking here for our passageway at pelvis, cervix, vagina, soft tissues of the pelvic floor.
Mhm.
So
Yeah,
all,
I said that, right? No, I didn't
yeah,
say
you
it.
guys got you
I
guys
didn't,
got a lot of them.
I didn't say any of that.
So if we think about our pelvis, do you guys remember what is the ideal pelvis shape for delivery?
What is it?
Gynecoloid.
Yeah, your gynecoid. Awesome. Yes, we want a gynecoid shaped pelvis. That's going to be the most ideal for delivery. What does our cervix need to do during labor? What are the things that happen to it?
Often.
Hmm. What does our cervix need? What needs to happen to our cervix? It needs to become fully
Soft.
Get effaced.
fully effaced, and we need to get complete dilation, right? That all is happening on our cervix. Which you guys should remember too, like our effacement is the thinning of the cervix. The dilation is the opening of the cervix. Okay? And you can't really have one without the other. Typically, we see moms efface before they dilate. Not always, though. But typically, our cervix has to get really, really thin before we can dilate it to 100 to 10 centimeters. Okay. And then I briefly mentioned our soft tissues of the pelvic floor. Why is that important? That's going to help us push, right? Those are that tissue on the pelvis or on the pelvic floor is where mom has to try and push from. Okay. So, like, you'll sometimes see providers during deliveries, which I'm not sure how many of you have had babies or have been in for a delivery or have been in with somebody who's had a baby. But during delivery, sometimes providers will put two fingers at the like base of the mom's vaginal opening, and that is those are the muscles that mom has to push with. Okay, so that pelvic floor plays a huge role in pushing out that baby. So we need to make sure that that is going to be adequate for delivery as well. Okay. So we answered this already. What pelvic type is the most common in women and is conducive to vaginal birth? That's our gynecoid, right? Which one, if you guys remember, increases the risk of having a C-section? What would be like an unfavorable one?
The baby oxygen level drops.
I mean, more like I'm sorry, I asked that wrong. Pelvis shape.
Ah.
Would it be the
But yes,
anthropoid?
that would be a reason to have C-section.
Anthropoid.
Anthropoid. Yeah.
Here we have them all. So we listed them. So 50% of women have gynecoid. That's the round shape, which is the most conducive to vaginal birth. Your platyploid is the one that's the most uncommon. It's a flat and oval shape, and most will require a C-section. Okay. Your anthropoid is not as common as a gynecoid. It makes the descent in the pelvis a little bit slower, and it's the second most favorable for a vaginal birth. And then your android, which I always think of like the phone whenever I read that, is going to be your heart-shaped, and it's a common like male pelvis shape. So the potential for a C-section is higher because the fetal head engages in a weird way, either to the side or from a posterior position. So that one's not as favorable, but I want you to know your gynecoid is the most conducive to vaginal birth, and your platyploid is the most that's going to require a C-section. Okay. And typically with this, with pelvic size and shape, we're not really figuring this out until we're attempting a delivery or we're like going in to deliver. Like most of the time, unless there's like infertility issues, providers aren't really doing pelvic exams routinely, right? So this might not be a known fact until we get to the actual labor part of the whole process. Okay, here are some pictures for you of a gynecoid pelvis, which is that round shape you can see here. Your anthropoid, which is the oval shape, which also is fine, and the second most for the favorable for a vaginal delivery. Your android, which is the male pelvis shape, which is more of a heart shape pelvis. And then your platyploid, which is mostly going to have a C-section because babies won't be able to pass through this shape, which is the flat and oval. Okay, but I would definitely remember your gynecoid is the most conducive for a vaginal delivery, where your platyploid is going to require a C-section. What is it called when a fetus drops or engages into the pelvis? Do you guys remember this term? It's our lightning. And this typically happens later in pregnancy. Or like if you see, which I don't know if it's just because I'm pregnant, but I've been getting so many pregnancy videos on Instagram, I can't even handle it. Um, but I have like the influencer ladies that are like, I think my baby just dropped. So whenever they say that, they're referring to lightning. Okay, that's the actual like medical terminology for it. But sometimes you can see it like a mom's pregnancy, like her belly will be up a little bit higher and then baby will drop down into the pelvis and her belly will all of a sudden like hang a little bit lower and her belly just looks different. Okay, this typically doesn't happen until third trimester, late second, third trimester. But that's when baby engages into our pelvis. We need this to happen, right, in order to have a successful delivery. We can't start a labor or successfully deliver a baby if that baby's head isn't even down in the pelvis, right? So when we're measuring labor progress, when measuring labor progress, a woman may be reported to be 3 centimeters, 40%, and -1. What does this mean? Is she close to having this baby?
No. Well, no. Because she's only 40%.
Yeah.
And you need to be at least 6, right? And 6 is kind of when things pick up.
6 is your active phase. Yep. Yep. And a lot of the times hospitals, which it's heartbreaking for moms that come in, sometimes the hospitals won't even do anything to help speed your labor up until you're like 5 or 6 centimeters. So if you come in and you're like, oh, I'm having these contractions, they've had these contractions on and off for like 3 days, and they check your cervix and you're only 3 centimeters, and they keep you for 2 hours and you haven't made any cervical change, guess what? You're probably going to go home, unfortunately. unless there's like some other medical indication that requires you to deliver earlier or something. But um, so what this is meaning is that the cervix is 3 centimeters dilated, right? 40% effaced, so that cervix isn't really super thin yet, right? We're not even halfway thinned out. And the presenting part is 1 centimeter above the ischial spines. So is that baby's head super low?
No.
Like close to the vaginal opening is what I mean.
No.
Not really. I mean, it's not like it's -3, so we can still feel the presenting part, which is good. But that doesn't necessarily mean um, she's going to have a baby within the next hour, right? So this is how you're going to see that terminology written on your tests, or even just like if you decide to be a labor nurse. We're always going to describe a sterile vaginal exam as 3 centimeters, 40% -1. We don't usually say the words effaced, dilated, or station, which is what all of these things are referring to. We just kind of say it 3 centimeters, 40% -1. Okay. So dilation, effacement, cardinal movements, and our mechanism of labor. So all of these things are going to be affected by the shape of our pelvis and our fetal position. Okay. Here's a really good video showing you the movements that baby will go through as they're being delivered. Okay. We're going to go through each one of them. So first we have to have our engagement. Okay, that is when our baby's head is going to enter into the pelvic inlet. That's when baby's head is pressing down on the cervix, and we can usually feel it when we perform a cervical exam. Okay, we need to have engagement in order for labor to be progressing and for labor to be effective. Descent is what happens or occurs whenever baby is descending down through the vaginal canal. Obviously, we need that to happen to have a delivery. Flexion occurs whenever baby's head is flexing to try and open up to come into the cervical opening for delivery. Our internal rotation. This is what happens whenever the baby's head is adjusting to our pelvis. They're kind of getting in a good position. They're feeling where they need to go in order to come down through the birth canal. So that internal rotation is baby's process of adjusting to our pelvis shape and size. Extension is this last part here right now, where baby's head is extending to come down through the opening. And then that external rotation is that last little turn you saw baby make in order to get the shoulders and the rest of the body to fit down. Okay? So we have that engagement. Let's go through it together. We have descent. You see how baby's head is descending down through the vaginal opening. We have our flexion, where baby is tucking in and coming close so that they can fit down through this pelvic inlet. That internal rotation that we saw when head adjusts to the pelvis, we see baby's head extend. And then finally, we have that external rotation for the delivery of the shoulders and the body. So it's all one smooth, fluid movement. But it can last for a couple hours, you know what I mean? This isn't necessarily as fast as this video is showing us, right? That'd be kind of crazy, because this is showing us from the start to finish of everything. Any questions about that? And then obviously your birth. We just didn't have that pulled up. But yeah, then your baby's born. Okay. Factors affecting labor power. What are our primary or our secondary powers? We're going to go through them here. Valsalva's maneuver. Would that be a primary or secondary power?
Secondary.
Yep. What is that?
Is that with the urge where the mother want to bear down?
I'm having a hard time hearing you, Linda. Can you come a little closer to your camera, your microphone?
Okay. Is that where the mother have the urge to bear down?
Yeah, so that is when moms are forcefully exhaling against like they're starting to bear down.
Okay.
Yep. What about our contractions during labor? Would that be a primary or secondary power?
Primary?
Yeah, primary. Adds force to uterine contractions to augment the forces of involuntary contractions. So we're basically adding force to already existing contractions. What would that be describing, really?
That's the like inducing labor, isn't it?
So in this instance, I think we're referring to mom pushing, the act of pushing. It's just written in a really funny way, but this would be secondary. So if we're adding force to uterine contractions, that could be mom pushing, yeah. So mom bearing down would be adding force to the contractions already happening.
So what is all right, so what's another example? What is an example of adding force? I guess that's what's throwing me because I took it as we're adding to the contractions that are already happening.
So I think in this it was referring to pushing. And that would just be like mostly mom's effort. But what you were saying isn't incorrect about inducing labor or like inducing contractions. But if it's before the pushing stage, that would just be primary powers. It would just be strengthening our contractions that are already occurring. So, in this sense, with pushing, I just don't like the way that it's written here, but that would just be your secondary. So, your secondary power is anything that mom is doing to contribute to the force of contractions, whereas your primary powers would just be like your uterine contractions on their own. So, then
Are all contractions involuntary?
almost, yeah. Yeah. Um, I think it does get a little confusing when we're talking about induction or like adding Pitocin into labor to strengthen contractions. Um, if we're adding force to something or adding force to contractions, I would say that would be secondary power. Okay. So then, like this one, our voluntary pushing effort of the laboring mom, that would be our secondary power. That feeling of wanting to bear down, like that uncontrollable urge to bear down, would be a primary power because that is we're not actually pushing it. That's just the feeling of what our body is getting us ready to do. The process of shortening or thinning of the cervix during labor or effacement would be our primary power because these are things that your body is naturally going to be doing on its own, right? And then the process of dilation of the cervix until it's fully dilated would be another example of a primary power. Okay. So pretty much our primary powers are things that your body's going to be doing on its own and naturally. So contractions, the urge to push, shortening or the effacement of the cervix, dilation of the cervix. Secondary powers are referring to like mom actively pushing or us adding things to make the contraction stronger. All right. Power. So whenever we talk about this, we're obviously going to start talking about our contractions and start getting into reading and interpreting fetal heart rate tracings. What is our frequency? Frequency, duration, and strength of the contractions. So how do we measure that? Each of these things.
Do you start with the the, the time of the contraction to the time of the next contraction?
And that would be our what?
Would that be your duration?
So that would be your frequency. To the start of one
frequency?
contraction to the start of the next contraction would be your frequency because it's telling us how often we're getting contractions.
Okay.
But yeah, uh-huh. So you got that one. Our duration is what you were talking about, and that is from we're measuring just one contraction, the start of one to the end of one. That's telling us how long they are. How do we measure the strength?
Like on the strip, you can
You
see like
see?
the peaks.
What about palpation?
Palpation. Unless we have what? You're completely right. We have to always um, measure our strength of a contraction using palpation of the mom's abdomen, unless we have what? That gives us an actual reading.
Mm,
An intrauterine pressure catheter. That would be
okay.
an internal monitor.
Oh, okay.
Hmm. So the strength of contractions, we can't go by. So I know, Gladys, you had mentioned that you can see where the number goes to for the contractions, which that is a question I get asked all the time at the bedside. Whenever dads or whoever are watching the monitors, they're like, what does that number mean? Does that mean how strong the contraction is? And then they'll be like, whoa, that one just went up all the way to 190. And you feel the mom's belly, and it doesn't even feel like anything, right? So, unless the mom has an internal monitor, we cannot use the numbers on here to tell us how strong our contractions are. It's not reliable. Um, we have to palpate the mom's belly during a contraction, and will rate it as mild, moderate, or strong. Okay. So if you need some reference, some point of reference, a mild contraction is going to feel like if you feel the tip of your nose. You can still pretty much indent mom's belly, her abdomen is still probably like almost what it would be like if it was just resting normally without a contraction. Moderate would be your chin. So it's a little bit harder to push down, you know. You can still feel it gets a little bit firmer, not too bad. And then strong contraction would be your forehead. And that is what we want to have really effective, strong contractions. We want the mom's belly to feel that hard during them. Okay, that's how you know the contractions are going to be effective. With an intrauterine pressure catheter, we can actually zero out the machine and it will give us a number of how strong the contractions are. And then if you're like running Pitocin or you're running an induction, then you can use that to say, okay, do I need my contractions to be stronger? Are my contractions too strong? Where are we at with this? Okay. Oh, we're going to do a little practice here. Okay. Miss Chang is in labor with her first baby. Her contractions started at 8:12:15 and ends at 8:13:25. The next contractions start at 8:15:15 and ends at 8:16:25. The fundus is difficult to indent with fingertips during the contraction and is soft between contractions. So this would mean if we're reading this over here, our contractions are going to be 3 minutes apart, 70 seconds long, and that belly is going to feel moderate. We would consider those contractions to be moderate. Okay. So that's the terminology you would use whenever you're defining a contraction or contraction pattern, is you would want to say how long, how far apart they are, so 3 minutes apart, how long each contraction is going to be, so 70 seconds, and then it palpates moderate, how strong or firm. What do we want our frequency and duration to be? In order for labor to be effective, what do we want those numbers to look like?
You want them more like a minute or upper?
Lower? Yeah, I'm also I think of lower,
You want them a
less,
little closer
further.
together.
You want the contractions to be more. consistent, a little quicker, I guess.
Yeah. We want them to be about 2 to 5 minutes apart and last about 50 to 90 seconds. That is our standard for contraction pattern. Okay. If you have a mom who comes in and she's like, "Oh, I've been having contractions. They're every 3 minutes. They're lasting about a minute and a half." And then you put her on the monitor and you're looking at the monitor and she hasn't had a contraction the entire time she's been on the monitor. She's probably just feeling Braxton Hicks contractions or her contractions spaced or something like that. But we want them to be every 2 to 5 minutes ish and then about 50 to 90 seconds long. What would be a tachysystole like contraction pattern? Or what would a contraction like how long when we're like nervous about it? What would be concerning?
Would it be when there's like maybe 5 or more contractions within 10 minutes?
Yeah, so that would be a contraction every minute or 2 minutes, right? So that would be definitely be tachysystolic. Definitely. Yep. So more than 5 contractions in 10 minutes or contractions that last longer than 90 seconds. So what are we worried about here? Like, are we worried about why would we be worried about this contraction pattern or tachysystole? Why would we be worried about that? Are we worried about mom in this situation or are we worried about baby?
Um,
Both.
Baby.
well, with the blood
Oh,
pressure. So if it's like going faster, your heart's beating faster.
So if there's a tachysystolic pattern where you're having too many contractions back to back to back to back to back, the first thing that we're going to be worried about is our baby because of fetal oxygenation, right? During
okay.
a contraction, that uterus is squeezing, 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 squeezing. It's providing pressure on the umbilical cord. It's squeezing baby's head. It's reducing the amount of oxygen that baby is getting through the placenta and the umbilical cord during that period of time when the mom is having a contraction. Okay. Typically, healthy babies, healthy pregnancies, those babies have a reserve that they can pull from, and that doesn't do anything to their heart rate. They look perfectly fine, they look normal. After a while, though, of that repeated reduced oxygenation, that's going to start to affect our baby, right? Because that baby only has so many stores available to pull from. So that is why we don't want our contraction pattern too close together. We want to give that baby enough time to recover in between them so that they can be well and resupplied with via oxygen for the next one. Okay. From mom or a maternal standpoint, if we have a tachysystolic contraction pattern, excuse me, that can increase our risk for uterine rupture. Okay, because like we talked about, our uterus is a giant muscle. Okay, so if you are continually using the same muscle over and over and over and over again, it's going to get really tired, right? Just think about it like in instances of like you go to the gym, you're doing, I don't know, lat pull downs or something, who knows, and you're doing 50 of them in a row. Towards the end there, your arms are going to start getting really tired and they're going to start to give out on you and they're not going to be able to do what they need to do. That is the same exact concept as the uterus. So if you're exposing that uterus to a lot of contractions back to back, it's going to wipe your uterus out and it's going to get tired and it won't be as effective. And sometimes it can get injured. Okay. Does that make sense? Why we don't want that pattern?
Yes.
Yeah. And then we kind of talked about this. We can quantify the strength of contractions by putting in an IUPC. Has anybody seen an IUPC or had, I guess, if you want to share, if you during your labor, if you've had an intrauterine catheter? Um, they're pretty cool. They're just little, they look like Foley's almost, and they go up through the cervix and they rest along the uterine lining. Um, and they basically give us a numerical measurement of our contraction strength. IUPCs are also really helpful because through an IUPC, we can also give an amnio infusion. So you can hook up bags of fluid and run them through the uterine pressure catheter to add more fluid into the amniotic fluid area for baby. If like baby's having recurrent decelerations or something's happening and the baby looks like they're in distress, the amnio infusion can add more cushion to the baby and help them during labor. So IUPCs are pretty handy. All right. So let's start. I'm actually going to run to the bathroom really quick. So if anyone else needs to take like a quick bathroom break, please do that. And then we'll go into our fetal monitoring. I'll be back in like 5 minutes. Okay.
Okay.
All right, guys, if everyone wants to come back, let's go ahead and finish out class. We only have like 45 minutes left, so we're doing good. Okay. So we talked about contractions. Anyone have any questions about how to read contractions on the monitor or what we're looking for with contraction patterns? At the end of class, we might be able to have some time to practice. We'll see where we end up. Okay, let's talk about our fetal baseline. Oh, sorry, did somebody say something? Nope. Okay. So our baseline fetal heart rate is the average rate over a 10-minute window. We have to have at least 2 minutes to be able to read a baseline, okay, without any changes. Our normal baseline ranges from 110 to 160 because that's our normal fetal heart rate, right? So in utero, when we're monitoring the baby, it's not going to be any different. Okay, so on a fetal heart rate tracing, we're looking at this top section here. That's going to tell us that has everything to do with our fetal heart rate. The bottom section on your tracing is going to be your contraction pattern and your contractions that we're going to be reading. So that's how it's split up. So on this here, every red line is indicating a minute. Okay. So the big red lines would be 1 minute apart. The smaller squares are each 10 seconds. Okay. You have your numbers here. Like I said, ignore the ones for the contractions unless you have an intrauterine pressure catheter. But the ones on the side for the heart rate is going to tell you what your baby's baseline is, or your baby's heart rate. So when I'm looking at this tracing here, and we look at it, this is a 1, 2, 3, 4, 8-minute strip. Just kind of looking at where baby's heart rate is consistently, I'd say our fetal baseline is about 145 because it's a little bit under that 150 mark. It's not necessarily on that 140 line, which is right down here. So I'd call it right in the middle. That'd be 145. So our normal baseline should be 110 to 160. Okay. When we're talking about variability, what is that referring to? What are we looking at specifically?
Is it the fetal autonomic nervous system?
So you're getting really in depth. That is awesome. Yes. I mean, mostly like if you're looking at the fetal heart rate tracing, what do we want to see whenever we're talking about variability? What is that talking about as far as like baby's baseline heart rate?
Is that where it's absent, minimal,
Yes.
moderate, or marked?
Yep.
Is that like the consistency of your,
Of our tracing.
yes.
So yeah, I see what you're meaning by that. Yes. So when we're talking about variability, we're talking about how much change are we seeing in the baseline? How much deviation off of this baseline are we seeing? Okay. So like I want to use a better term or a more medical term than the word squiggly, but like that's the only thing that's coming to me right now. So how squiggly is our line? Okay. That's like what we're gonna try and just go with that. So in this tracing up here, we have our fetal heart rate baseline of 145. We see that there's a lot of activity. That's what the word we can use, activity. A lot of activity on this fetal heart rate tracing. So I would say this is a moderate variability. That baby is reactive. It's looking good. But yeah, like Linda said, we're splitting this up into minimal, moderate, or marked.
Well, you know what?
Or
I looked it up. I print out your PowerPoint and looked this stuff up.
I appreciate it. I'm glad. I'm glad it's helpful in some way. So our and when we're talking about variability, if there's absent variability, that means there is absolutely no squiggling of the line. That baby's heart rate is completely flat. We're looking at a flat line. That is really bad. Okay. Minimal would be less than 5 beats of a difference. So that heart rate isn't increasing or decreasing by 5 beats off of our fetal heart rate baseline. So say you're looking at this tracing, right? And we've determined our baseline is 145. And we know that these are going up by 10 seconds. We want that heart rate to accelerate up by at least 5 to 25 beats for it to be good variability. If it's staying all in one line, that would be absent. If it's not going up hardly at all, but it is going up or there is some deviation off the baseline, that would be our minimal. Our moderate would be 5 to 25 beats above or below baseline. And marked is greater than 25 beats. So marked is when your baby's in there going crazy. Like your heart rate is like I don't want to call it like VTAC or anything like that, but it kind of looks like VTAC. So your variability is basically how squiggly your line is, how much activity we have in the fetal heart rate baseline, and then how many beats off of that baseline baby's heart rate is excelling. Okay? No, the word squiggly is not going to be written in your exam, unfortunately. So definitely know your beats parameters. Okay?
So with this monitoring, it's going to be moderate, you said?
Yes, this would
It's
be a
okay.
moderate variability here.
Okay.
Yep. So we kind of talked about it already, but our variability that is the best that we want to see is our moderate variability. That means that our baby's doing good. We've got a lot of good oxygen stores. We're perfusing to the placenta effectively. That baby's doing great. That baby is loving life. Okay.
Okay.
What would a definition of an acceleration be? What are the parameters that we want that acceleration, excuse me, acceleration to be in as far as like beats increasing or decrease or off of baseline? Josue, go ahead.
Professor, I have a question. It's different from what you
Oh
asked me.
yeah,
Did we have a quiz at the beginning of the test?
we did.
No? Oh my God. I'm sorry. I missed it.
It's okay. If you want, we can stay after class and talk.
Okay, perfect. Thank you.
Yeah, no worries.
Are you,
So when we're talking about our accelerations, there are some specific parameters that we want to see, especially in a term baby, okay? So we want an increase from the baseline at least 15 beats, and it lasts for at least 15 seconds. Okay, so we're looking at this baseline, it's 145. We want that baseline to go up by at least 15 beats and it last for at least 15 seconds. So this one over here at the far right where that little arrow is pointing, that is an acceleration. Accelerations are awesome. We want that baby to excel. That usually what we say whenever we're reading that on um, a tracing is that baby is happy. That baby's excited. If that heart rate is going up off the baseline, that means that baby is excelling and that is a great thing. Okay? Any questions about our baseline or our variability? Awesome. Okay. So now we're going to get into the world of fetal monitoring and decelerations. Okay. So we talked about accelerations, which are the really good things that we want to see. That's when baby's heart rate goes up. That was when we have a good deviation off of the baseline, that 15 by 15 change of an acceleration. If there is an issue with the baby or something is happening in labor, we will sometimes see what are called decelerations. And deceleration, if just think of the word down, okay? Deceleration down. The baby's heart rate is dropping down off of baseline if we're calling it a deceleration. Okay? We have four different types of, really three different types of decelerations. Okay? We'll start here with variable decelerations. So that picture up in the top here, you see those V's? It looks like a V. That first tracing that's right at the top of our screen. So that would be called a variable deceleration. That is what happens whenever we have fetal heart rate baseline and we have a really sudden drop off of that baseline and then a really quick recovery. Okay? These are usually abrupt. They can happen with or without a contraction. And they look like V's. That's the easiest way to remember it. That's how I even remember it when I'm charting on the floor. Okay. This little mnemonic over here, veal chop mine, I want you guys to definitely remember this. This is one of those things like during the exam, after you show me your whiteboard, if you're wanting to write down something before the test starts, this would be something I would write down. Okay, after you've shown me your whiteboard and after everything is ready for the test. This little mnemonic is going to help you remember what we need to do with a deceleration and whether or not it's okay or not. So our variable decelerations, like I said, that's that abrupt onset. That's that really deep, sharp decline off of baseline. What is usually causing this? It is usually caused by cord compression. That means that when that uterus is contracting, it's putting a lot of pressure on the umbilical cord and it's cutting off that baby's oxygen really quickly during the contraction or even just randomly during labor. That reduces the baby's heart rate dramatically. What is our solution for a variable decel? We need to move that mom. If we move her into a different position, we might move her to a place where that umbilical cord isn't going to be getting squished as badly during a contraction or just during labor itself. Okay? So that would be our V, our C, and our M in our veal chop mine mnemonic. Early decelerations. That's the second picture that we have right underneath the variable decels. Early decelerations are not bad. And what I want you guys to remember is that early decelerations are going to mirror your contraction. That word is probably the best thing that is going to help you remember early decels. They mirror the contraction. So they start and end at the exact same time as your contraction. You can line them up and they're going to match each other, mirror each other perfectly. Early decelerations are typically caused by head compression, so that is not something we're super concerned about because, a baby's head can get squeezed. That's really not reducing their oxygen, right? That's not really an emergency. Baby's going to have a little bit of some squeeze during labor. That's just a normal part of it. So, what are our interventions? We don't need to do anything. We don't really need to intervene. Taking it a step further, if I see these on a monitor, typically what it means is that mom is making some serious change and that I probably want to go in and see how far progressed she is. But that's above and beyond. You guys don't really need to know that. But earlies are okay. Accelerations, we already talked about that. Those are those increases off of the fetal heart rate, those when baby's heart rate is going up off the heart rate, and they last at least 15 beats by 15 seconds. Those are okay. That means that baby is very well oxygenated and we do not need to do anything at all. Okay? Late decelerations. Late is the worst. Those are the worst kind of decelerations, really. The ones that we worry about the most. Late decelerations look a lot like earlies. The only difference is the start of the decel happens after the contraction starts. Okay? So here on this picture at the bottom, you see your contraction, it starts. It's going up, it's going up, it's going up. Right at this peak, here we go, baby heart rate drops. It recovers, we have another contraction, and then, oh no, that contraction's almost done, but that heart rate is dropping. Okay? So in a late deceleration, our fetal heart rate drops after the contraction starts. This is really dangerous because late decelerations are indicative of placental insufficiency. So that baby is not getting oxygenated correctly. Okay? This can be caused by a lot of different things, not necessarily things that we're going to figure out while the baby is still in utero. But basically, what we need to know is that this baby is not getting oxygen and we need to do something about it. Okay? Is mom laying flat on her back? Are we experiencing some supine hypotension? Did mom just get an epidural and her blood pressure dropped dramatically? That can cause placental insufficiency, right? Any issue like that. So there are some things that can cause babies to have late decels that we know for sure is what's causing it, but other things we're not sure. So we need to figure out why. So our E in the mnemonic is evaluate why. So we're doing all of the interventions for these D cells. We're going to change mom's position. We're going to put her probably on her left side because that's where placenta is going to be perfused the best. We're going to administer oxygen. What we do when our moms are in labor, we give them 10 liters of O2 via non-rebreather mask. That's our standard. We're going to start an IV fluid bolus. That's going to support mom's blood pressure. That's going to help with placental perfusion, right? That's going to keep her hydrated. That's going to keep her vital signs stable, especially if this is the instance where mom got an epidural and her blood pressure just randomly drops, okay? We're going to notify our MD. We need to tell our doctor. If we're doing any type of interventions during labor, your doctor should definitely know about them, okay? Because we may need a C-section because that baby isn't doing well during labor. Tocolytics. If you have oxytocin, which we haven't really talked about that too much yet, but if you are giving the mom anything to make her uterus contract more or to make her labor stronger, you better turn all that off, right? Because if you're doing any interventions, the first thing you have to do is make sure that your oxytocin or anything that you're doing in utero or to the mom or to the baby is stopped. Okay? So that is our little mnemonic for those interventions that you guys can have as a reference. This is the point. So your position change, your oxygen, your IV fluid, you're notifying your doctor, and your tocolytic. So you're turning off oxytocin. Okay? So we need to remember our late D cells are the worst ones, and they are going to occur after the contraction starts. Give me 1 second, guys. I'm going to move to the back room because my dogs just woke up from their nap and they want to play. So give me 1 second.
I was about to sing some transition music, but you made it already. Darn.
It was a very short walk.
Almost had me.
All right. Does anyone have questions about D cells? Okay.
I'm sure I'm going to have some questions. I can't formulate them right now because, yeah, I got to process things.
That is fine. Anytime you guys can reach out to me if you need anything clarified.
Well, like I said, it makes sense. I just haven't figured out how I'm going to like memorize it yet or learn it to where I don't even have to memorize it, really.
That's fair. It is, I think honestly, using and referring to this veal chop my mnemonic is really helpful because it is a lot to remember. Um, that was how I kind of remembered it whenever I was in nursing school. I wrote this mnemonic like everywhere.
I wrote it down. I'm gonna go through and I'll find some way to, you know what I'm saying? Like make stuff stick out. Like, oh yeah, that's that. And oh yeah, that. Yeah.
Yeah. And also, I'll show you guys a good link that you guys can use to practice. It like runs actual like fetal heart rate tracings, and then you have to kind of work through it and give like basically like tell us what the heart rate is, the baseline. Are we have any accelerations? What else is going on?
Oh, that sounds fun. Yeah, I'll take it.
Oh, I like what you sent too, Miriam. That's also really helpful. Yes, the tocolytics, the remember the trick. Yes, that's really great. All right. So, factors affecting labor, positioning. So, the position of the mom has the potential to facilitate or hinder descent of the fetus in the birth canal. Regular position changes during labor can relieve maternal fatigue, increase comfort, and improve circulation. What positions should we consider, and what effect could these positions have?
Oh well, the question's on here. Never mind. Okay. Position.
So what is this like what is whenever you see like on TV or whatever, a mom
Mhm.
is on her back with her feet in the stirrups. What position is that called?
Ooh.
Litho no.
Lithotomy.
Lithotomy.
Yep,
Lithotomy.
lithotomy. So that a lot of moms deliver in lithotomy. Not everyone has to, right? Um, they actually say that lithotomy is not the most favorable position for childbirth because, you're not really using gravity to your advantage. The pelvis shape is not necessarily awesome, but it's the one that we see the most common, especially with moms that get epidurals because it's the easiest for them to position into. Another position that we could use, let's see, hands and knees. Hands and knees is awesome, and I've helped deliver a lot of babies in this position. Um, what it does, it relieves backache due to back labor caused by fetal occipito-posterior position. So if you hear a mom say or a doctor say, "Oh, that baby was born OP," it means that baby was sunny side up. That baby was not in a good position for delivery. Or that occiput was in a posterior position. That baby's head and the lie and mom were not conducive to an effective labor. Okay. Hands and knees also is great because it facilitates fetal internal rotation by increasing coccyx motility. Okay, so hands and knees, basically what that means is it's opening up mom's pelvis. It's getting her in a position where that baby can rotate and do that internal rotation that we saw in that video earlier in class. Because we're making her coccyx, we're moving her in a position that's going to facilitate that change for baby. Hands and knees is great. Another position that we want to know is our side lying, which we can also refer to as lateral recumbent. This position is great because it enhances uteroplacental perfusion, right? So we're getting that placenta really well perfused in this position. It decreases that pressure on mom's vena cava. So, like in lithotomy, she's technically on her back. She's flat on her back, right? So we tell them throughout the entire pregnancy, you shouldn't sleep on your back. Don't lay on your back. If you're in your back on your back, that's bad for the baby. And then they go to deliver and we're like, okay, lay on your back. Like it doesn't really make much sense. Oh, what just happened? Hold on.
Are my superpowers working?
How did that just happen?
I have no idea.
All right, let me pull that back up really quick. 1 second.
I believe I can fly. I believe I can fly. Somebody remind me.
There we go. Okay. Weird. I don't know what just happened, but we're back. All right.
Oh, stop.
Okay. Sorry about that, everyone. So our side lying position, it's also going to take pressure off of our perineum. which is going to help with pushing in during labor. It's going to facilitate that fetal internal rotation, that posterior to anterior position, and it's going to just in general help speed along our labor process, okay? The side lying position, also some moms just in general find way to be way more comfortable than your standard lithotomy or even just hands and knees. It's more of like a resting position. So even in between pushing, they're able to kind of relax a little bit better. There's not as much sensation or as much pressure that they're going to feel in between the contractions, and it will just oxygenate baby very well. This sometimes is a position that we have to push in if baby is not handling delivery very well at all. Okay. So if you're pushing with your mom and all of a sudden your baby starts having late decelerations and she's in a standard lithotomy, we're going to try and put her on her side, right? That's one of our interventions is repositioning mom. So if you're pushing with that patient and there's decels, then we need to change her position. We can also have mom push or in semi-Fowlers. Or even labor in semi-Fowlers. It's more convenient for external fetal monitoring, especially if like you're running Pitocin and you have like contractions that you have to be monitoring. It's really easy to monitor contractions in semi-Fowlers. Some gravity pressure is going to be exerted to promote fetal descent in this position too. An upright position. This is the most effective use of gravity, right? If you have mom sitting like straight up with her knees like kind of crisscross applesauce, not really like the bottoms of her feet touching and her knees kind of like falling out to the side, that's opening up her pelvic inlet to promote fetal descent. So we're having gravity be our friend in this situation. Gravity is helping us. It also increases impulses from the cervix to the pituitary gland, making primary powers more effective and efficient. Because what hormone or what is being released from that pituitary gland? If someone knows this, I'm going to give you a gold star.
Can you ask that again, please?
Yeah, what is being released? What does our pituitary gland release during labor, during breastfeeding?
Oxytocin.
Pitocin. Yes. Awesome, Josue. That's great. So if we're impulsing and we're increasing impulses from cervix to pituitary gland, that's increasing the amount of Pitocin that our body is producing, which is going to make our contractions stronger. Pitocin is what is helping our contractions. All right, critical thinking question for you. What kind of factors could affect a laboring woman's position? Really, a lot, anything goes here.
Exercise?
Yes.
Also like if they're like person that's like contracted or has like certain deformities or like
Physical
um
limitation.
Yeah. Yeah, definitely.
What about cultural practices?
Yes, definitely, for sure. I've had like Amish women who don't want to move out of any position besides just sitting straight up in bed, and they will labor that way the entire time. Um, Not necessarily all Amish, but they are a little bit more stoic of a culture, so they usually just kind of act like nothing's happening. So it definitely depends on culture for sure.
Um, what about previous injuries like a hip or back injuries?
Definitely, definitely. If you have a mom who's ruptured her tailbone or broken her tailbone or something, she's not going to want to be in a lithotomy or sitting position. We're going to need to put her in hands and knees, probably. If moms have pre existing back problems, hands and knees is another really good one for them. What about like if a patient has an epidural? That's going to affect it, right?
Yeah.
Because there's certain things that people with epidural, like some moms with epidurals can't do. Like if we need her to turn on her side, like that involves getting some people in there to help us move. If we need to get her on hands and knees with epidural, that's kind of hard because her legs might be too numb. Let's see.
Would anxiety or fear be one?
Yes, for sure. Yeah. So big ones that we have listed here, mom's pain level, right? If mom is not able to be is to the point where she's in the active phase of labor, she is not tolerating her pain very well. She might be limited on the amount of positions she wants to be in. She may have decided I am going to lay on my right side because that is the only place that I can be laboring where I don't feel like I'm not going to be able to do this, right? So we need to listen to what mom wants to do and how mom is comfortable. If she is a mom that we're having a hard time monitoring her baby, and the only way you can monitor her baby is if she's sitting up and we need to really make sure that heart rate is okay, that is the position that she's going to have to be in, unfortunately, because that takes precedence. That's priority, right? Monitoring the baby is the priority over mom's comfort at that point. How tired is she? Is she just absolutely exhausted? Because if she's been laboring for 24 plus hours and she doesn't have an epidural, she's going to be exhausted. Her legs are going to be weak. Having her stand at the bedside or even doing hands and knees could be dangerous. What is she the most comfortable in? And then fetal tolerance. Some babies don't tolerate sitting straight up for a long amount of time. Some babies don't tolerate, like I said, that lithotomy position. So we always need to be monitoring our babies and monitoring them and to make sure that they're still doing okay. Which positions allow for gravity to aid in the fetal descent during labor? Select all that apply.
Kneeling,
Standing, kneeling. What did we
sitting,
say lithotomy was? That's the laid up in the. Well, that might be. Can they
Lithotomy,
do that? Like, elevate the bed up a little bit when they're in the lithotomy?
you can, yeah, you can. Typically, we don't typically because sometimes bringing that head up while their legs are up will close the pelvic inlet. Just the way
Okay.
the anatomy
Yeah.
works. Yeah.
So we
So
B
the
and
answer will be like B,
B and E
D,
B, D,
allow
and
for
E.
gravity.
B, D,
Yeah.
and E.
Yeah.
No,
Stand.
E, no, no. Standing, no, right?
Yeah. Standing. Yeah.
Yeah, yeah, that's good. Okay.
So
So
B, D, and E, or is it just B and E?
B, D, and E. So kneeling, sitting, because you can still be like your head elevated and open up the pelvis, and then standing, which I've helped moms deliver babies while they're standing at the side of the bed, and it's really cool. I mean, it's super messy, um, and you have to make sure that the baby is safe, but it's really cool, and that's definitely a possibility if mom wants to do it that way. So, even though sideline position is used frequently during labor, it's the least effective for using gravity to facilitate fetal descent, right? All right. Ferguson reflex is the term to describe which of the following actions during labor.
B,
Yep.
desire to bear down,
Yeah, you got
Oh,
it.
she is on it.
She's got this. And then what phase of labor is that? If a mom's wanting to push,
That
is
the
that the first?
Second.
that would
second.
be your transition phase during the active phase, right? We don't know if she's complete yet or not, right? But this stage could also be our second stage. Okay. So to clarify, our first stage of labor, right, is that latent phase until we get to 6 centimeters. And then 6 centimeters until we're complete would be our active phase or our transition phase. You can have an urge to bear down during that transition phase of the first stage of labor. Okay. but we don't technically call it second stage until we check that mom's cervix and we're like, yep, you're complete. Let's have this baby. Okay. All right. Factors affecting labor, psychological. How is mom coping? Right? How's she doing with labor? Does she have a history of sexual abuse? Because that is greatly going to impact how we not only provide bedside nursing care, but the experience that she may have during her labor. Okay. Let's decide if this is appropriate or inappropriate for us to say. It's time to open your legs and relax while I examine you. This will not hurt much.
Inappropriate.
Yes, inappropriate. I'm going to assess your vaginal area to look for any bleeding. I will just look. It will not involve any touch.
Appropriate.
Appropriate. Who would you like to be present while I examine you to determine how much you have dilated?
Appropriate.
Appropriate.
Appropriate. That's fine. Yep. I'm going to examine you to determine how much you have dilated. Can I ask everyone to leave the room? It will only take a few minutes.
Appropriate.
Appropriate.
And was it inappropriate? 'Cause
Appropriate.
you didn't ask what the patient wanted. You just assumed she didn't want anybody there. She might
Yep.
have wanted support.
Inappropriate. You really should not be having people leave the room unless the patient asks for them to leave the room. So that one above it is asking their preference on who they want at the bedside. That's what you have to do throughout their entire labor. Okay? So
So that would be
everyone,
inappropriate.
what'd you say?
Would that one be inappropriate?
Yeah, that last one is inappropriate for sure. Okay. If a patient has a history of sexual abuse, okay, that is greatly going to impact how we're talking to them and how we're assessing them during their labors. Okay. If I know a patient that has sexual abuse history, I am not going to be performing excessive amounts of vaginal exams, period. Maybe not even any, if that is what the patient's desire is. Okay. If she has a history of sexual abuse, I'm going to ask another nurse potentially to come into the room with me just to be a support person for that patient while we're doing any type of exams, unless the patient requests fewer people in her room as possible. Okay. Everything for the patient, even if they don't have a history of sexual abuse, should be their preference to as much as we can provide as long as the baby and the mom are safe, right? So
But, yeah.
just being mindful of that, and using that in the back of your mind whenever you're providing care, right?
I try to think of it as like patients like when they feel like they have control or you so whatever I think about what power can I give them. The more
Yes,
stuff I take away, the less comfortable they'll feel. So don't take away the people, don't take away the options. You know what I mean? Give as much as you can, and that'll probably be the answer.
definitely. And patients, especially in labor and delivery, are not always going to do things the way that you would do them, and that's okay. Like, I've had it before where there's been a patient, and the only person that she wanted in the room with her at the time of delivery was her significant other, her partner. I've also had patients who have had their uncle, their dad, their cousin, their niece and nephew, their own other kids in the room, and there's a room full of like 25 to 30 people. And that is okay as long as we can safely provide for the mom or the baby, right? If something were happening and the baby's heart rate's dropping, that's when you could maybe interject and say, there are some things that we need to do with mom right now to make sure that her safety and baby's safety is the priority. If a couple of you wouldn't mind waiting in the hallway, that would be greatly appreciated. Okay? And that's all you really need to do. Um, and also at that time, usually your provider's in the room with you, and the provider can be the bad guy and kick people out if they need to. But moral of the story, we need to provide the care that the patient wants, okay? Take into consideration what they want rather than what we deem to be necessary, okay? So let's go through these instances and tell me whether or not you think that this mom is coping effectively during labor. She says that she's coping.
Okay.
Coping. Yeah, we have to take her word for it, right?
Mhm.
Rhythmic breathing.
Not
Yeah.
coping.
Coping.
I would
Coping.
say coping. So rhythmic breathing is one of the things that we encourage moms to do as a coping mechanism during labor. So that's like counting your breaths in and out, slowing those breaths down, making sure that they're stabilized. Okay. Relaxes in between contractions.
Coping.
Yeah.
Coping.
Yep, coping.
Brace
Panic
yourself.
during contraction.
Not coping.
Scooping.
Not
Not
coping.
coping.
Not coping.
If mom's like squirming and getting up out of bed, or she's like yelling or not able to take big deep breaths, usually she's not coping because she's panicking, and it's more of like a stress component than anything. She's not able to focus.
Not coping.
Not coping, correct. She's really tense.
Not
Not
coping.
coping.
Not coping. Controlled moaning, counting, or chanting.
Coping.
Coping, yeah. So those are all things that we would encourage moms to do. We tell them these are things that they can do during labor to help. What if she's tearful?
Not coping.
Coping.
That can
No,
still
not
be
coping.
coping.
He's like
Either.
accepting and
Tears
being
don't
emotional.
necessarily mean
That's
sad.
normal.
So this could be normal, right?
Mhm.
So we need to talk to her a little bit more. We can't just be like, "Oh, she's crying, she needs an epidural." Like, no, we need to just like kind of go into the bedside, wait until the contraction passes, and then kind of investigate a little further, right? We need some more information. Her voice is trembling when she's talking to you,
Not coping.
Not
Not
coping.
coping.
not coping. Rhythmic activity during contraction.
Coping.
Coping, yep.
So what is an example of that?
She's rocking back and forth.
Okay.
She's doing that deep breathing or timing her breaths or counting her breaths. Um, some moms, if they're sitting on a birthing ball, will like sway their hips side to side, that kind of thing.
Gotcha.
So if she says that she's not coping,
She's not
Lies.
coping.
she's not. Just take her word for it. Just listen to her. If she's thrashing around in her bed,
Not
Not
coping.
coping.
Yeah.
not coping. So these things, like when we're talking about thrashing around in bed, sometimes people are going to be like, so what? Let her labor how she needs to labor, right? If she doesn't want an epidural. If she's thrashing around in bed, do you think it's going to be easy for us to monitor her baby's heart rate?
No, because hers and the baby's gonna be dancing.
Yeah, that baby, we're not going to be able to put any monitors on her because she's panicked and so stressed to the point that she's making it very difficult. And in the instance when labor becomes active, we are worried about mom and we're wanting to help her from a coping standpoint, but our number one priority is ensuring that mom is safe and that baby is safe. So if we can't accurately measure baby's heart rate, we need we need to get mom in a different position. If she's focused,
Coping.
Coping.
coping, yep. And then as a nurse, how do we support moms that are coping well with labor? What can we do?
Encourage them, tell them good job.
Yeah,
Continue doing what you're doing.
Supportive.
yeah. We just still provide support regardless if they're coping or not. How can we support a woman who's not coping?
Um, ask, I guess I don't want to say the right questions, but ask the right questions because, whatever's bothering her is probably something we may be able to take care of.
Yeah, definitely.
Maybe ask if she needs something.
Yeah, ask her if she needs something for pain. Ask her about her labor preferences. What does she want? If there's anything that you can do. And sometimes even just like staying at the bedside with your patient is all they need, right? Just stay in there with them and be a source of calm, a calming source for them, and help talk with them through this time. Okay. Is it labor? Little game here that we're going to play because one of the things that you guys need to know for your exams are signs and symptoms of labor. Okay. If mom has bloody show, do we think that she's going into labor?
Possible.
Yeah.
Maybe.
No.
Possible.
What else can cause moms to have some bleeding?
Maybe like dental abruption
Yeah.
or
Placenta previa?
Her
Placenta
body's
previa is
adjusting,
one. Uh-huh.
yeah.
stretching and moving.
Implantation bleeding.
Yeah, that would be early, but yes, that's definitely one. In like later trimesters, we tell moms too that like if they have sex, there can be some bloody show. Okay? Which is not necessarily a cause for concern. So appearance of bloody show is a maybe. It's not definitely we can't tell. What about irregular contractions? Does that mean
No.
Not necessarily. Could mean something's wrong.
so irregular contractions could mean um, depending on her gestational age, right? This is always dependent on how far along mom is. If she's having irregular contractions, those could be Braxton Hicks. Those could just be preparing her body to get ready. Braxton Hicks contractions are not signs and symptoms of labor. They're just preparing mom to go into labor eventually. She's lost her mucus plug. Does that mean she's in labor?
No.
You can lose your mucus plug at like 36 weeks and not go into labor until 40 weeks. So your mucus plug is not an indicator if you're in labor or not. She is making cervical effacement and dilation. Her cervix is changing.
Yes.
Yep, she's in labor. Spontaneous rupture of membranes.
Yes.
Yes.
So that
No.
could be no, and that is tricky because spontaneous rupture of membranes that can happen sometimes early. And sometimes, whenever the mom's water breaks, she still doesn't have any contractions and her body still is not going into labor on its own. So just because her water has broke does not mean her body is immediately going to start going into labor. It just means she's going to have to come into the hospital and be monitored.
So, but does that mean like the process has somewhat started?
So, not always, and that's what's the most confusing part about this. So, just because a woman's water has broke does not mean that she's in labor. Okay, that's not a reliable indicator, I should say. If she's over a safe age where the baby can safely be delivered and we can have the baby, then we're probably going to help um, augment her labor and help keep it going or start it. But just because her water breaks does not mean that she's automatically going to be going into labor.
So what is the water? Where is it?
That's her amniotic fluid,
Right. That's what's around the
the
baby. Yeah.
baby. Mhm.
Right. So once that drains out, baby's just in a dried out water balloon, just there.
So usually you still are producing amniotic fluid even throughout labor after your water ruptures, but if a mom's water breaks, we always have them come into the hospital because their baby's going to have to get monitored. And most of the time, either we're inducing the mom, helping her go into labor, but she doesn't necessarily have cervical change or regular contractions just because her water breaks.
How long can you last with your water broken before you actually go into labor?
So some moms, their water will break and they never have contractions on their own. And we have to give them Pitocin or we have to give them something to start the contractions. Other moms, their water breaks and they start contracting right away. Typically, providers do not let moms go longer than 48 hours having their water ruptured before they're at least considering doing a cesarean section.
So
Okay.
the baby still get oxygen through the umbilical cord,
Yeah.
through mom in general. Okay, so the fluid is just okay. All
Fluid.
right. Yeah.
Yep. So that fluid is just going, that water, that amniotic fluid around is just what's leaking from mom. But the placenta and the umbilical cord are all still intact, so baby should still be getting oxygen and nutrition.
Okay.
That baby, if baby contraction pain felt above the navel, not necessarily. We need regular strong contractions that are causing cervical change. If your baby has dropped into the uterus or into the pelvis, not the uterus, into the pelvis, does that mean she's in labor?
No, because didn't you say sometimes the baby can go just from sitting high to sitting low?
Yeah.
And then that's kind of it.
Yep. Yep. So lightening is not a good indicator that mom has gone into labor. Contractions continue to increase despite comfort measures. So her contractions are still increasing. They're getting stronger. They're getting closer together.
Yes.
Yep. Contractions go away whenever the mom's walking.
You got me.
If her contractions stop, do we think we're in labor? No. Mm-mm.
No.
So they
Nope.
never stop until they keep going until that baby comes out once they start.
Yep, that's labor. Yep. They should not be good contractions are going to be strong. They're going to be like every 2 to 5 minutes apart, 50 to 90 seconds, and they do not go away with intervention. So even if you drink water, you walk, you move, you take a hot shower, they still stay the same. If mom hasn't made any change in her cervix, is she in labor?
No.
Nope. And then her contractions are increasing in severity and frequency. So those contractions are getting more close together and they're getting stronger.
Yes.
Yep, she's in labor. Okay. All right. I'm going to send you guys some practice questions because I said that we could get out early and I mean it. I'm not going to make you guys go any longer than now since we didn't take our break. There's a lot of this PowerPoint that I still want you guys to go over because there's a lot of really good information towards the end of it that might be on your exam. Okay. So, what I want you to do is do your best during this week if you have time to go through the rest of the PowerPoint. The practice questions at the back, I will send like I did in the course cafe, and then I'll send the answers later this week. Okay, but I want you guys to still do this PowerPoint because I think it's going to be really beneficial for exam one. Okay?
Okay.
All
So,
right. Anyone have questions?
so the end of the rest of the slides that are still left, um, can you send what you have, like as far as the answers, or do you just want us to kind of look it up on our own?
So I want you guys to try and do it on your own at first, okay? But then I will send out important information that I think is going to be beneficial when we're answering the end of this PowerPoint because there are some really good things like that I want you to focus on whenever we're talking about epidural management and that kind of stuff. But so try to answer it on your own. If you want to send me the answers that you have and then I can correct them, I will do that. If not, I will send out the answers towards the end of the week if you guys want them. Okay. But a lot of that information that's at the end of the PowerPoint, I talk about a lot in my recorded lecture, is on the PowerPoint, like for this, just the general information. So definitely try and do it on your own and then send me what you have and I can go through it. Okay. Awesome. Well, you guys did great today. That's a lot of content. Please check that exam review, uh, the exam one review session announcement in Canvas and try to go to at least one of those if you can make it. Okay, I think that'll be really helpful for you guys studying for exam one. But if you don't have any other questions, you guys are free to go for the evening, and I will see you maybe Friday if you come to my review session or next week. Okay, thank you guys so much.
Goodbye.
Like I said,